Hi, Andrew Penn back again talking about anxiety disorders. In this module, we're going to talk about a very common complaint, which is insomnia. And we'll talk about what causes insomnia, how to assess for it, and how to safely use hypnotic medications. So we'll cover all these different areas here. And we'll also talk a little bit, in addition to talking about medications, about the tricky issue of cannabis as a medication for sleep. So circadian rhythms, circadia means about a day, like circa means about, and dian means day. And these are the biological rhythms which in part control our need for sleep. And so you're probably quite familiar with these just from your things you've already learned, but also particularly if you've ever traveled overseas, you've experienced jet lag, and jet lag is a classic disruption of circadian rhythms. And so it's not just your alertness, there are other biological functions such as your bowels, your appetite, your blood pressure, your sleep obviously is the clear one, and we have this we have a circadian rhythm which occurs. It has two peaks in it. So we have one peak of energy around 11 o'clock in the morning, and then that dips down. And if we were in some parts of the world, we would take a siesta, but instead here we usually drink more coffee. And then there's another peak around 5 or 6 o'clock, and that starts to decline again as we get closer and closer to bedtime. And there are different drivers for this, but one of the main drivers for this is melatonin. So melatonin is produced when it's dark. And so it's produced in the brain. It's a naturally occurring hormone, which starts to signal the shutdown process. So it's like when you shut down your computer and you close all your programs and you go ahead and start shutting it down. That's what melatonin's doing. So melatonin is produced in response to darkness in order to signal our start of our dormant period or sleep. And as soon as we get up in the morning and we get bright light, it shuts off and we start to wake up. And so this is the physiologic reason for the recommendation not to have bright lights in your face in the hour or two before you go to bed. So when we ask about insomnia, we really need to ask every patient about their sleep. And when we're doing that, we don't want to just stop with asking how much. Some people just say, I sleep fine. And it's always good to get operational definitions of what that means. So I'll say, how many hours of sleep do you get? They say, well, I get 6 hours. Do you get that all in one chunk, or do you get that, is that broken up? And then when we talk about identifying insomnia, we usually talk about early, which is insomnia at the beginning of the night where they can't fall asleep, middle or maintenance insomnia where they're waking up in the middle of the night, or then late insomnia, which is usually like the last hour before they would normally get up when they wake up and they can't fall back asleep. And then the bottom line is, how do they feel the next day? Because, some people can get 6 hours of sleep and they feel just fine. Other people need 9 hours of sleep to feel rested, and that's going to vary from person to person. So the right amount of sleep is the amount of sleep that gets you through the day with awake and alert and not needing a whole bunch of stimulants to keep going. I also ask about breathing problems when people are sleeping. So obviously they can't tell you usually, but their bed partner can. So I'll ask them, has anybody you share the bed with ever told you that you snore or that you stop breathing in your sleep? Because what I'm looking for there is the possibility of sleep apnea. And that's where usually because of an obstruction, which is a soft tissue in the airway, starts to collapse. So when we're sitting upright, it's held open by gravity and muscle tone. But as we lie down and we start to relax, that tissue, it vibrates when we're snoring, and then it can fall all the way closed. Now, of course, our brain isn't going to let us suffocate to death, so it will cause us to stir. And so that's the sort of sound that your bed partner would hear. And then the person will go back to breathing normally, maybe go back to snoring, and then there'll be that apnea. You can also have central sleep apnea, which is where the signal to breathe is suppressed. And that's common in people who use opiates, be they prescribed or non-prescribed. There's also a phenomenon what I call insomniophobia. I don't know if that's really a term, but I'm going to make it one. And that's just this fear of having insomnia, and it becomes this vicious circle. So, a lot of times people have a bad night's sleep, and then they're afraid, oh my gosh, I'm so tired today. What if I can't sleep tomorrow? I can't keep going like this, right? And then, of course, disruptions in one's sleep as a result of nightmares or parasomnia. So parasomnia is referred to behaviors that you do in your sleep. Sleepwalking is the classic, but sleep eating can happen. People can have sex in their sleep and not remember it. And then you always want to think about sleep hygiene before you reach for medication. So there's a great course called Cognitive Behavioral Therapy for Insomnia, CBTI, which addresses a number of different areas of insomnia, but one of them is sleep consolidation. And that's essentially picking a wake-up time which stays consistent. And regardless of how little sleep you got the night before, you stay up, you try and stay up until you can't stay up anymore. You get up at that same time. And what this does is it after a few days of this, the person becomes so tired that they actually start falling asleep earlier and they stay more deeply asleep. And that can kind of reset the sleep pattern. I also really tell people not to nap, because I say, a nap is like a sleep snack. And, just like your parent probably told you, you can't have a snack at 5:30 because you're going to eat dinner in an hour. You want to be hungry for dinner. You want to be hungry for sleep. So not napping is a really good way to keep your sleep appetite up. And then, of course, exercise and mindfulness, relaxation type exercises during the day can be really helpful. Exercise in the first part of the day often helps with sleep. So we often talk about primary sleep disorders or insomnia disorders that don't necessarily come along with a psychiatric diagnosis. And this is sort of your classic insomnia that is happening frequently enough that it's become a problem. And then there's secondary sleep problems that are related to other psychiatric conditions. So many people, for example, with depression will often have late insomnia. So they will wake up, or early morning awakenings, EMAs, sometimes you'll see that abbreviated in charts. And what that means is that they're waking up at like 5 a.m. when they want to get up at 6 and they cannot fall back asleep. Now, often, interestingly, when you treat the depression, the sleep will get better. Mania, of course, disrupts sleep. That's axiomatic. PTSD is notorious for disrupting sleep. And then you can have secondary sleep problems as a result of medications. So things like bupropion, if taken especially too late in the day, or a stimulant for ADHD taken too late in the day, can cause insomnia. But also things like prednisone is notorious for causing insomnia. And then, of course, the stimulants that we use, caffeine or non-prescribed stimulants like cocaine. Sleep apnea I've talked about. Chronic pain is also a huge disruptor of sleep. Fibromyalgia in particular often comes with sleep disruptions. You see sleep pattern changes with dementia. You often see people sleeping during the day and being awake during the night, and often getting confused at the end of the daylight hours. So sundowning is referred to. Restless leg syndrome is this sort of like creepy crawly feeling that people get in their legs just as they are falling asleep. And it causes them to kind of twitch or feel like they need to move their legs, and that keeps them from falling asleep. And then narcolepsy is the inability to maintain wakefulness, and it's not terribly common, but it is out there. So, I talked about some of this already, but, your basic sleep hygiene, a lot of patients will think about sleep medications as being the magic answer that's just going to knock them out and they don't even have to worry about trying to fall asleep. And I always tell them, like, look, what this sleep medication is, it's going to nudge you into sleep, but you've got to help it out. And the way you help it out is by doing things like going to bed and waking up around the same time every day, minimizing your caffeine and alcohol use before bed. Because of course, caffeine, or alcohol rather, will get you to sleep, but there's no extended release alcohol. And so oftentimes somebody who passes out from drinking will wake up 3 or 4 hours later, usually feeling kind of lousy, dehydrated, and having to pee. And then they often have a hard time falling back asleep. The idea of using your bed for sleep and sex only is to essentially associate the bed with sleep, not with frustration. So if you can't fall asleep after a reasonable amount of time, I'd say half an hour, you get up, you get out of bed, so you don't get in that conditioned response of feeling frustrated when you're in bed. Keep the light really low. I always say get like a 25-watt bulb and just read something boring. The voter pamphlets are great for this. And then learning how to relax. So things like mindfulness or progressive relaxation. A lot of my patients have enjoyed using the Calm app on their phone, which has these sort of guided meditations and white noise generator. It's a great little app. And then if you're not sure what's going on with sleep, you may want to get a sleep study. And so a lot of these sleep studies can be done at home. They're usually comprised of like a band that goes around the chest to measure movement, or sometimes it's even just a wristwatch that has a pulse oximeter in it. And what it's looking for is a characteristic pattern of desaturations of oxygen followed by movement. And that's that pause 30 seconds and then restless movement, stirring, and then going back to sleep. So if you see that characteristic pattern throughout the night, that often can give a sufficient diagnosis of sleep apnea, and the person can begin to use a CPAP or continuous positive airway pressure machine to keep that airway open so that the breathing continues. This is a great book. It's a popular press book, but is really well written by a professor over at Berkeley, and I highly recommend it. So if you are going to do medications in general, and I'll talk about the specific meds in a moment, but you want to think about 2-for-1s. So if you're treating somebody with depression who also has insomnia, a sedating antidepressant like mirtazapine can be really helpful in treating both conditions. If you're treating hypomania, you might think about a sedating mood stabilizer, possibly like an atypical antipsychotic that's sedating, like quetiapine or olanzapine. You want to be careful with meds in older people because of the increased risk of falls and of cognitive impairment. And you also want to be clear about what your dosage range for your given medication is, because otherwise I found that patients will feel like, well, if one didn't work, I'm going to take 2, and if 2 didn't work, I'm going to take 3. So if there's a dangerous point where you don't want the person to go past, you need to make that very clear. And you also want to counsel people not to combine this with other sedating medications, particularly opiates or alcohol, along with benzos, because those 2 are dangerous. Now, with any sleeping medication, you're looking for what I call the Goldilocks dose. So the Goldilocks dose is somewhere between not enough, which caused the person to wake up too early, and too much, which left them groggy until noon. But you're looking for just right. And this often, particularly with a medication like trazodone, which is a common one I'll talk about in a moment, is a matter of finding the right dose and the right time of taking it. And the timing is less of an issue. The dose is more important. But, for example, some people who are groggy for the first hour or 2 of the morning might benefit from taking the sleeping medication maybe an hour to 90 minutes before they go to bed. So you got to find that Goldilocks dose. So here's your first line agents for sleep, and you'll notice these are all non-benzodiazepine drugs. So trazodone has really become the classic. Now, I always tell patients, hey, if you go home and Google this, you're going to see this is an old antidepressant, and it says nothing about sleep. It's because we're using it in an off-label capacity. And that's fine if we do that. If that's a common practice and it's safe, that's fine to use a drug in an off-label capacity. But you want to have that as part of your informed consent, and you want to document that you had that conversation. Trazodone is typically used in these very small doses. So a typical antidepressant dose is like 300 to 500 milligrams. But for sleep, you can often get away with something as low as 25 to 100 milligrams. It's dirt cheap. It's not something that's going to cause dependency. Now, some people do feel groggy the next day, and there is a rare risk of priapism with this drug, although, knock on wood, I have yet to see that in my practice. Mirtazapine, as I mentioned earlier, is a very helpful antidepressant if somebody is also having sleep problems, but it can cause somebody to get a really intense appetite, and that can lead to weight gain. And of course, it too can leave somebody groggy the next day. Doxepin is an old tricyclic antidepressant, which has kind of enjoyed a resurgence as a sleeping medication because it has these anticholinergic and mostly antihistaminic effects that lead to drowsiness. Now it's being marketed in these tiny little microdose pills. I think the brand name is Silanor, and those are 3 and 6 milligram. 10 milligrams is the cheapest that the generic comes in, and that I often find works just fine for people without having to spend a whole bunch of money on a drug that isn't new but has just been put in a new package and charged for a lot more. Gabapentin was once sort of the darling of psychiatry until we found out that it wasn't that effective for the things we hoped it would be effective for. We thought it was a mood stabilizer. It's not. It's certainly used in chronic pain management. but it can be helpful in treatment of sleep because it is a little bit sedating, and there's a wide dosing range that you can use it on. Melatonin is also available over the counter. That's that hormone that your brain produces in response to darkness that signals the time to go to sleep. Now, this is good for getting somebody to fall asleep. So somebody who has early insomnia, initiation insomnia, it doesn't really keep you asleep. So for people that have middle or late insomnia, this is probably not going to be ideal. And, there is some question about the long-term risks of melatonin because it is a hormone. And it's not entirely clear if that comes with any long-term risks. So that would be something to just stay tuned to the literature around. Okay, so second line meds, this is including our what we call Z drugs, so things like isoprolol and zolpidem, they often refer to as Z drugs. These are GABA receptor agonists. They cause increased activity at GABA, which is an inhibitory neurotransmitter system. And these are, so zolpidem typically is dosed 5 to 10 milligrams, isoprolol 1 to 3 milligrams. A lot of people have heard of these, they're familiar with them. I have become less and less enthusiastic about the Z drugs in the 15 years that I've been in practice because I've seen just far too many cases of parasomnias, some which were kind of amusing, like, I don't know why there's cookie crumbs in my bed. I don't remember eating at night. And some that were alarming, like, I think I drove my car last night and I don't remember it. So I've really kind of put these almost like on third line for me at this point. And you want to be careful with older people because of the risk of amnesia and also risk of falls. And this is definitely something people can become dependent on for sleep. The benzodiazepines also have some utility in sleep. They all have similar mechanism of action. They all work exactly the same at the GABA receptor, but they have different pharmacokinetics. So some of them will get to work very quickly. Others, so like lorazepam usually gets to work pretty quickly, whereas clonazepam usually takes longer. So again, you're going to think about, if this is a patient who is having late insomnia, you might think about a clonazepam, whereas if the sleep problems are more in the first part of the night, a lorazepam makes more sense. But again, same problems with dependency, memory issues, and falls. There are antihistamines that are used for sleep, and most people are familiar with diphenhydramine or Benadryl, and this comes in a lot of the PM medications, so like Advil PM, Tylenol PM. You'll see this for a lot when patients come in for the first time. They'll tell you, I've been having sleep problems and I'm using Advil PM. And I'll ask them, if they're not having a need for an analgesic, why not just go ahead and use diphenhydramine? It's cheaper, and you're not putting additional drugs in your body that you don't need. And so that's an easy over-the-counter remedy. Hydroxyzine is a prescription antihistamine marketed under the name of Vistaril or Atarax that is also can be useful for sleep. Now, all these antihistamines have significant anticholinergic effects, which is why they cause your mouth to get dry, and sometimes people have a hard time urinating first thing in the morning or get constipated. And in older people, those anticholinergic side effects can lead to delirium, and they also can lead to memory problems. And of course, anything that's sedating in older people can increase their risk for falls. Quetiapine or Seroquel is a favorite off-label drug for some people to use with sleep. I think this also should be really a tertiary drug for when everything else has failed because of the metabolic risks of weight gain, dyslipidemia, and glucose derangement that you can see with the atypical antipsychotics. And then prazosin has a little bit of a carve out. So prazosin is an alpha adrenergic drug, and it's used in the treatment of PTSD. And what this does is it reduces some of the activation that comes with nightmares, which often leads people to feel like they don't have as many nightmares in the course of a night. And so the trick with prazosin is you want to dose it and go slowly. So 1 milligram increasing by a single milligram every 3 days or so. And the reason why you're doing that is because this can cause orthostatic hypotension upon awakening. And so what you don't want to have is somebody who gets out of bed to pee in the middle of the night and falls down because they've had an episode of syncope. And, when I was in outpatient practice in a civilian population, the most I would ever see of this was like maybe 4 or 5 milligrams. But now that I've been at the VA for a while, there are some heroic doses of prazosin going around, and I've seen 15, even 20 milligrams of prazosin to be the effective dose. So you can go higher, but you want to be thoughtful about how you're doing that, and also, of course, being careful with older people because of falls. Now, what about cannabis? I'm noticing in the last decade that a lot of people are kind of abandoning their sleep medications and they're turning to cannabis. Now, is that okay? Well, I think that's a clinical decision that you have to consider with each patient. Now, obviously, if somebody has a substance use disorder, this may be problematic, but with the increasing availability of cannabis, I'm hearing from a lot of patients who will use a small dose of a THC gummy or something like that before they go to bed, or a couple of inhalations from a vaporizing pen. You know, historically, the idea that cannabis indica, there's 2 strains of cannabis, which are often hybridized. There's actually 3 strains, but indica and sativa being the most common ones. Indica historically is thought of as being more sedating, but so many of these things have been hybridized that it really kind of depends on the different strain. Now, there isn't a lot of great evidence for this practice. There's certainly a lot of anecdotal data, and you know, I think you have to think about this carefully with each patient. And it may be that what cannabis is doing is actually reducing the anxiety, that insomnia phobia. And so the person actually feels like they got better sleep because they weren't stressed out about not being able to sleep. And also people that have chronic pain may sleep better with cannabis because they get the analgesic effects, which then prevents their pain from disrupting their sleep. So I think the jury's still out on this. You'll certainly run into a lot of it in clinical practice. I think each case is a little different, and you need to carefully consider if it makes sense for your patient to continue doing that. So sleep is really this regulation. It's regulated by this intersection of these circadian. And I didn't really talk about homeostatic mechanisms, but just briefly, essentially that is this buildup of adenosine, which occurs from cellular metabolism. So as you can think of it as the exhaust out of the tailpipe of cellular metabolism, right? So as that exhaust, as that trash sort of builds up, it creates more of what's called a homeostatic pressure for sleep. And interestingly, caffeine is an adenosine receptor antagonist. So it blocks that pressure for sleep that's caused by adenosine being built up in the cells. Now the problem is when the caffeine wears off, that adenosine is just waiting there to reoccupy those receptors. So that's why people will sometimes crash at the end of having coffee. But when we go to sleep, all that trash gets kind of swept out. And that's what helps us feel awake when we wake up in the morning. But it's that combination of the buildup of waste product throughout the course of the day, coupled meeting with the circadian rhythm. So when those two join, that's usually about 11 o'clock and you start getting sleepy. So you always want to think about correctable issues of sleep hygiene before you grab your medication prescription pad. And there are a lot of different things we can use for sleep, but ideally you want to be doing this only for short-term use. But many people often have chronic insomnia that needs to be managed. Thanks for your attention. And in our next module, we'll talk more about other medications used to address anxiety.